Good afternoon. SMI would like to welcome you to this very first in our series of leadership webinars for SMI members and their executive teams. We are very pleased today to have with us Ford Koles, who's the Vice President and National Spokesperson for the Advisory Board. Ford is one of the preeminent thought leaders in healthcare strategy and heads the faculty at the annual Advisory Board series of CEO meetings. He's a healthcare economist by training and has a wide and deep knowledge of healthcare reform and its many iterations over 28 years. Many of you have heard Ford speak before, and I know we will all gain some great insight from his comments on the complex healthcare environment we're facing today. For a little housekeeping, all of our participants are on mute for this program this afternoon, but we are taking questions. So if you have a question, please click on the questions or chat feature within this webinar and type your question in, and we will be happy to share it with Ford as the program goes along and as time allows. And now, without any further delay, we want to make sure we make the most of Ford's time today. So Ford, I'm going to turn it over to you, and we're going to give you control of the screen so you can share your slides. And we're going to get started with Ford Koles on the State of the Union in Healthcare. Thanks a lot, Ford.
Thanks, Nancy. It's an honor to be here, and thanks to SMI for hosting this excellent event. Something I look forward to every year. And thanks everybody for joining us. I know we have a mix of suppliers and health systems today, so it's always nice to get both on the line and talk through some of these issues. I thought I would begin, and again, please use the chat function to send me your questions. I would very much like to hear them. I thought I'd begin I use this as a framing slide for, again, my own experience with COVID. COVID's been interesting in a million ways, but one of the more interesting things to me is that we've experienced it really individually. It's not been a collective experience, at least the way I remember 9/11 being. Everybody has had different times when COVID became real for them. Some people it's when flights from China were canceled. For other people, it's when the basketball season suddenly just stopped. Remember that? I was at a tournament actually for my kids' high school team, and everybody just got up and went home. And obviously, it gets far more tragic than that for many people we know, right? We've had family members, many of us who have tested positive. Some of you have, I'm sure, lost people. But this I use to frame it for myself. We all remember phase one. My last business trip was March 12th. I came home and basically took out an elementary school eraser and erased my entire year. I'm sure a lot of you did that as well. Stage two was just terrifying, right? The kind of nadir, cancellation of electives, everybody wondering if hospitals were going to go bankrupt. Physician practices appeared to, be threatened with insolvency. The people in this call that sell into that marketplace obviously experiencing similar terror. And then phase three was far more positive, the great reopening, we call it, where health systems were convincing people they were safe and sharing video on Facebook about how they were wiping every surface down and spacing their appointments, and nurses, everybody masked and so forth. And then where we are right now is stage four, or phase four, which is a kind of uneasy piece or truce with COVID. We have different hotspots popping up around the country. The numbers are generally nationally much better. The upper Midwest, plain states have been having some trouble. Hawaii, all of a sudden, strangely, has gone from exemplar to troubled. But again, mostly, for the most part, the numbers are better. So we're in this kind of uneasy truce. But what everybody is wondering is what is phase five on the right, which is truly normal? When do we get back to something that is truly normal? I have a lot of health systems I work with who are telling me that they're at 102% of normal volume now. So that's great news, obviously, versus phase two. But they also ask me all the time, is this normal? Am I just making up for lost time and pent up demand? And in fact, things are going to get worse in the future and go to 95% of normal, or 92 or 97. Nobody knows, but that's the question I get. I should probably remind everybody, as a sobering reality, that it took about 2.5 years for things to be completely normal in hospital care after the Great Recession of 2008, 2009. Now, I'm not saying that past is precedent. The Great Recession was different. That was a financial crisis. There was a much longer downturn in the stock market, obviously. And, people lost, it was also a mortgage bubble bursting. So people lost a lot of their sense of net worth in the real estate market. So maybe that was a longer term hit than COVID. I hope that's true. But we get a lot of questions about what the new normal will look like. You can see here, the answer to those questions, I think, depends largely on what's on this slide, which is how has COVID changed the basics of how Americans behave? Again, the stuff that we talk about all the time that's in the paper every day is the stuff on the left-hand side, right? That Americans are more fearful, that we've had to convince them to come back to the health system, that it's safe, that we have the protocols in place, and also financial insecurity. How many people will lose their jobs or be furloughed or go part-time because of COVID, right? But I actually think those things will solve themselves more obviously and more publicly than the things on the right-hand side. Those are actually the bigger behavioral changes that we should anticipate in our patients. So for example, the patients will be much more experienced with virtual and home care. I'll give you one silly example in my own life. My mother has AFib, so she has a pacemaker defibrillator. She needs to check her INR, the thickness of her blood, every month, and she's always gone to a clinic. I've been telling her for years, they have home kits for that, Mom. You don't have to get in your car and drive to a clinic. You can do that at home. Oh, no, forget it, honey. Finally, with COVID, she ordered the home kit, and now she is happily using it every single month. Again, it took years. Actually, it didn't take years. It took COVID to get my mother to change her behavior. So, and that's one of tens of millions of examples of change behavior, which will have an impact, right, on volume in the industry. The other two on the right-hand side are kind of counterbalancing each other. One is people avoided an immense amount of necessary care. People had heart attacks and died at home in COVID. People had strokes and died at home, right? Some of these stories are just truly mind-boggling and terrifying, right? Nobody's done their cancer screening. Colonoscopies fell off, right? Cancer is a fast-moving disease, so this is dangerous stuff. On the other hand, we all know, you and I have talked about this many times across the years, that a lot of care is actually unnecessary. The numbers are debatable, but most people I've talked to in healthcare, wherever they work, whether they work in pharma, device, or basic services, or hospitals and health systems and doctors, everybody acknowledges that some portion of American care is unnecessary. Let's say it's 20 or maybe even 30%. Well, guess what? People have avoided a lot of those things, and there's been no ill effect. So I think we have trained the American public that some of the stuff that they used to do, they don't really need. And it's fine that that part go away, but we don't want them is to avoid the things that they truly do need. So again, where will we end up? What is the new normal? Depends a lot on how much the culture has actually changed. And if we do end up at 97%, I hear that number a lot, that we'll go back to 97% of normal. Well, then the next question is, of course, what's in the 3? Is that orthopedic surgery, which is very profitable? Is it, is it diabetes care? What's in the 3% that has changed? We have a long list of daunting immediate challenges, as you all know, right? We continue to treat COVID patients. There are continued hotspots. That's not going away for a while. Our mission and, in fact, our margin dictate that we also, of course, find ways to provide care for all of these non-COVID patients in the same way as well. We have to support our frontline clinicians who have had an immense emotional and physical toll in this epidemic, in this pandemic. We have to find ways to mitigate the impact on underserved communities. Obviously, COVID, we've all seen the numbers, has had a bigger impact in minority communities, in the urban setting, and also in rural communities. Both of those are traditionally underserved in the healthcare system, and the numbers have shown it. And then, of course, we need to continue looking forward to optimistically for a vaccine and treatment. But all of these things have to be done, and you're doing all of them. But I think you would agree with me that none of these things fix the longer term structural problems that we've seen as a result of COVID. So problems with, PPE, problems with testing, problems with the amount of inventory we have in different areas. In other words, exactly the kind of thing that the people on this call have to deal with every single day. What the pandemic has made abundantly clear, and I think no more so than in supply chain, is that the system is far more fragile than we would have liked it to have been. Look, I'm not going to bash the American system unfairly. We did really well by a lot of metrics. We didn't run out of beds. Even in the height of the crisis in New York City, the system bent, but it did not break. It did not implode. That is not true when I talk to the people I know who work in Northern Italy or in some of the Spanish cities. The Northern Italian healthcare system was at 100% occupancy before COVID, so you can imagine, and essentially imploded, sort of ceased functioning in many ways in the height of the crisis. That was also true of some cities in Spain. Those two countries, by the way, had the highest per capita mortality as a result. That did not happen in the American system. So again, but it also, we did have problems, right? We didn't have the resources we needed to deal with the surges or the financial strength to deal with some of the closures. Now, there's an obvious way, speaking of financial strength, there's an obvious way to solve this problem, which is a ton of money. We could legally require that every health system in America have a giant warehouse with stockpiles of PPE. We could keep vast numbers of beds and staff standing idle, ready for the next crisis. We could require that hospitals build up massive cash reserves to weather any kind of closure period. The problem, the deal, right? Nobody wants to pay for that. We're already massively in debt as a nation. There is no appetite for that at all. Affordability has been the rallying cry of payers for most of my adult life. So the question is, are we at a crossroads? And will durability on the left-hand side become more important than affordability? I get this argument a lot with people, right? That affordability, it had its time, but COVID has revealed problems, and we need to migrate as a nation to thinking about durability instead. My argument to you is that this is a false trade-off. That in fact, the requirement for all the people in this conversation is that we are able to do both of these things, that we can deliver against both of these ambitions. And I think, and I will show this in my slides today, that that is the path forward, that resiliency is the answer, which is a mixture of the two. That the answer is not in brute strength or massive reserves of cash, staff, and supplies. It is in more efficiency. It is in other words, the kind of things that the people in this call who work on supply chain have been trying to pull off for a while. Agility, the ability to quickly respond when required, flexible structures that make that agility possible. So that is the big ambition that I think for everybody in supply chain that I want to unpack. Amid all the challenges that we're grappling with, I should also note that this has been a time of optimism in terms of decision making. I've seen, I've seen a lot of leaders in the health systems I work with who are not letting a crisis go to waste. I don't mean to be flip. I mean that they're making hard, good decisions. I hear all the time from CEOs, I'm making a decision I should have made 5 years ago. I'm making a decision I should have made 7 years ago in terms of our service portfolio or the way we interact with consumers or the way we do access. A million stories about good decisions made in a troubled time. So again, COVID has had that benefit, certainly. All right, in terms of our time, we have about 45 minutes. I'll walk you through these 4 areas. We won't be able to do all of them. I'll give an executive version, but what's going on with purchasers? What is going on with partnership? In other words, are we seeing a massive consolidation trend? Fire sales, hard hit physician practices that are selling out. The answer, by the way, is no, but it's still a risk. Care model redesign, what's going on with care model redesign? And then, of course, basic operations, what you folks do in supply chain, how do we make sure the supply chain is functioning and efficient? All right, let me get in. I'm going to cover the 4 major purchasers, Medicare, Medicaid, employers, and then for each, it's worth asking, have their motivations changed in terms of affordability? Let me just, again, spoiler alert, no, but they are being more subtle about how they pursue these things during a pandemic. I'm also going to dedicate some time specifically to talking about health plans over there on the right-hand side. All too often, frankly, and most of you have seen me talk before, I typically just lump the health plans and the employers in one category that I call commercial. But I think health plans have their own unique set of circumstances and challenges and motivations in COVID, and it's worth looking at those separately in this talk. All right, let's start with the biggest insurance company of them all, Medicare. Even before CMS started dispersing tens of billions of dollars in COVID relief, as you can see, spending was accelerating fast for Medicare. The reason is next year, the baby boomers will start turning not 65, but 75. This is a world of difference from 10 years ago. I want you to notice an interesting statistic. Per capita Medicare spending has surpassed enrollment as the primary driver of spending growth for the program for Medicare. Imagine that. That's a hell of an achievement because we still have about 11,000 people a day turning 65 as the baby boomers enter their Medicare years. So 5 years ago when you and I talked, enrollment was driving spending growth in Medicare because of these massive numbers of new 65-year-olds. It's an amazing thing to tell you that per capita spending has surpassed it, meaning sickness, illness has now surpassed even the ability of baby boomers to turn 65. That's a driver of growth. If this were any other insurance company, and this were not a time of COVID, I would be telling the people on this phone call, tighten your belts, folks, because you got some price cuts coming. But it is Medicare, and it is COVID, and that has not manifested itself as yet. Indeed, you can see on the next slide, hospitals and health systems are poised to get even larger price increases in 2021 than either of the past 2 years. Let me just say, I wouldn't read too much into that. These proposed rate increases were already being discussed pre-COVID. So CEOs always ask me, is this a COVID bump, a generosity bump? No, this is actually already underway before COVID. It's also, frankly, not a good read, I think, on what CMS's post-COVID strategy on reimbursement is going to be. But again, I don't want to quibble. Let's take the good news where we find it. Despite all the financial pressure on the Medicare Trust Fund, we are not looking at major price reductions in Medicare right now. This is great news for the people on this call. That does not mean, by the way, that other forms of spending control have been taken off the table. In fact, CMS is working hard, if you look at the right-hand side of the slide, to keep momentum going in 2 areas, in particular site of care shifting. And secondarily, value-based care. A lot of the value-based care, the ACO program, for example, has been a little bit postponed or delayed. But again, these are the 2 points where they're working. Let me show you what I mean. Site of care shifting is nothing new for CMS. They've been working to move procedures out of the hospital setting and into the outpatient or ambulatory setting for a long, long time, as you all know. What we're seeing, though, are some particularly bold moves proposed for this year. So this rule dropped about a month ago, thousands of pages. We've been pouring through it. To start, CMS has proposed a complete elimination of the inpatient-only list. Look at the bottom left-hand side. That's new. If this proposal is finalized, again, these are proposed rules and not finalized, every procedure done in the hospitals on this call will be subject to the 2 midnight rule by 2024. Obviously, you will still have a lot of discretion over what is done as an inpatient procedure versus an outpatient procedure. But what I want you to notice about this move is the signal value of it. This is a loud broadcast of the intentions of CMS to shift things out of the inpatient setting when safe and possible. Again, it's a proposed rule. It may very well be overturned, but there's no question about the intention that we're seeing here. Also, an increased emphasis, on shifting to the home, particularly through virtual channels. I'll talk a lot more about that because, of course, it's not just a Medicare trend. Historically, CMS has looked to shift site of care by attacking facility regulations and facility reimbursements. In other words, exactly what I put on this slide for you. But one of the big things that caught our eye additionally this year are some very significant corresponding changes on the physician side. As you can see on the next slide, part of their commitment, again, to recognizing and pushing the value of care delivered outside the hospital setting, CMS is proposing big payment increases for evaluation and management services. So basically, anything that's provided in the office setting. The catch, of course, is they have to keep these changes budget neutral. So if they increase rates in one place, that requires an offset somewhere else in the system. We don't have to get into the math. We can do that later if you want, because it's complicated. But the real upshot here is that surgeons are poised to get a significant pay cut, while primary care physicians and specialists, in other words, those who work largely in the office, oncologists, for example, are poised to get a notable pay increase. Again, this is proposed, it's not finalized. CMS is already facing a lot of backlash from the proposal, so I don't know if it will be finalized as is or not. But what I want you to notice, what I want everybody here to realize, is the signal value again. It's crystal clear how they want things to move. One last point on Medicare, but it's an important one. I give you right here the sort of macroeconomics of Medicare and the trust fund. The federal government's main priority right now, as you all know, is to prop up the healthcare industry and make sure it's functioning and solvent in COVID. The desire to control spending has not gone away. Again, what we're seeing is a more indirect push on things like site of care, which I've shown you already. But I want to be clear, I am not saying that you won't see price cuts in Medicare in the near future. We are approaching a key inflection point for Medicare. Look at the red bar on the right-hand side. Generally, there's always a lot of panic and hyperbole around the Medicare Trust Fund. Every time the Congressional Budget Office releases the numbers, you hear panic, no matter where the numbers are. But my point is bigger than this. If you zoom out and look at the history of the trust fund, you see a crystal clear pattern. Every time it gets near this low, Congress, every single time, has stepped in and acted. They've raised taxes, they've raised Medicare premiums, they've cut hospital reimbursement. Sometimes they've done all three of those things together. If you look at where we are right now, over there on the right-hand side, we're right in the sweet spot for where Congress historically would jump in with both feet. This could be even further accelerated if, for example, we successfully lobby to turn all of these accelerated payments into grants. That would further deplete the trust fund and increase the urgency for Congress to act. So Medicare price cuts are not on the docket for this year or even for next year. Let me just tell you, I believe they're a very real prospect in the 3 to 5 year window, and that we should be loading that into our strategic planning. What we're experiencing right now is a short-term COVID relief, not a permanent relief. That's Medicare. Let's talk Medicaid. Medicaid is feeling much more immediate urgency. It was a huge target in the Great Recession. It's likely to be an even bigger target this time around for obvious reasons. It's been greatly expanded since the Great Recession. Remember, the Great Recession was before the Affordable Care Act expansion. So Medicaid, is an even larger share of state budgets, particularly obviously in blue and purple states, than it used to be. And of course, that's not even taking into account any impact from COVID and unemployment. Now, the good news is the CARES Act offered states a lot of temporary relief, federal money. The bad news for the states is, as you know, that money came with strings attached. In order to get the enhanced federal match, states had to agree not to cut Medicaid enrollment and not to cut Medicaid benefits for the duration of what is the technical public health emergency. The minute that is lifted, I think you're going to see an unbelievable amount of pressure to cut prices in Medicaid, because these states, by law, have to balance their budgets. Again, they can look for savings elsewhere: education, labor, pensions, infrastructure, bridges and roads, and so forth. But I got to tell you, we've looked at some of the states in more detail. It's going to be really, really difficult for them to find enough savings to balance the budget without really going after Medicaid. What about the newly unemployed? The best data we've seen came from the Urban Institute. These are their numbers showing what we could expect. I think this is sort of a worst case scenario, but 48 million Americans possibly impacted by job loss this year. Again, I think kind of worst case scenario. They're projecting that only about 20% of those people, though, would lose employer-sponsored insurance, or ESI. The reason for that is most of these folks didn't rely on their job to get their insurance to begin with. They got it elsewhere. Among those 10 million or so possible people who could lose insurance, Urban Institute breaks out on the right-hand side. It's a pretty even split. 34% would become truly uninsured. 32% would switch to the insurance plan of a family member or spouse. And then 28% would go to Medicaid. Notice only a very small proportion would be expected to sign up for the exchanges in Obamacare. The reason for that is they have high deductibles, so there's a real disincentive to join one of them later in a calendar year. Ultimately, there's no way to sugarcoat this reality. Most states are going to have to resort to significant price cuts on Medicaid in the near future, again, when the public health emergency is lifted. We saw this in the last recession. State Medicaid directors are already sounding the alarm. So absent some kind of sustained intervention from the feds, if you do the math, things would have to be even harsher this time around. So that's Medicare and Medicaid. What about employers? States are on a similar trajectory to the last time, if only more intense. Employers are in a completely different situation than the last time, than the Great Recession. You can see what happened coming out of 2008 and 2009 here. This is a survey done of 329 human resource professionals on the left of American companies. 62% of them, almost double any other strategy, said that they were going to increase employees' sharing of healthcare costs and coverage. Meaning, what came out of the Great Recession was basically a social contract. I'm not going to lay you off, but you're going to pay a ton more for healthcare. Man, were they not kidding. As you all know, the last 10 years following the Great Recession has been the era of the high deductible health plan. Now, I did a talk about a month ago with 130 benefit managers at major American companies, and I will tell you that not one of them raised this as their expected strategy for the next run. Interesting, no? I give you the reasons on the right-hand side. First, in many markets, the deductibles are already so high that companies don't perceive there's a lot of running room left. They've already done this. Second is public relations. The optics of jacking up the deductible in the midst of a pandemic are horrible, right? And probably most importantly, there at the bottom, healthcare is a bright spot in terms of company budgets this year. All that deferred care, all those canceled electives, all the avoiding of the ED actually have employer healthcare spending trending notably under budget for 2020. So at the end of the day, employers who are feeling financial pressure from lower sales and so forth and COVID are not going to be looking to health benefits as the solution. The savings aren't big enough or fast enough to offset any declines that they've seen. Now, that is not to say that they won't look to control spending. What I'm saying is it's not altering the strategy that was already in place. And what we're seeing with employers, in other words, is a notable continuation of a story that we've been telling for a few years now, and that story is best summed up with the word steerage. For all the talk of the promise and peril of high deductible health plans, I'm going to argue to you the most important impact they've had was actually unintended. They made consumers far more open to steerage. Look at that graphic on the left-hand side. 15 years ago, if you asked an American, commercially insured American, what part of your benefit is most important to you, all they said was coverage, coverage, coverage. Big fat PPO, endless choices, no restrictions if I want to see specialists. Only a third would have even mentioned cost. Look at the right hand of that. Those numbers have almost perfectly flipped. A decade and a half of experience with high deductible health plans has made commercially insured Americans desperate for affordability. And frankly, they're willing to trade on some of the coverage aspects in order to get that. If anybody asks you, what have high deductible health plans meant for our business? I would show them this slide. I've not seen it told better. It's a huge unintended change in attitude. Employers, by the way, clearly recognize this. When I talked to them in that big conference a month ago, they brought this up over and over again. Instead of cost shifting, they're focusing on strategies to steer their workforce and their family members to lower cost settings of care. Concierge navigation services, right? All kinds of interesting stuff like second opinion services. And of course, most popularly, Center of Excellence contracting. We've been talking about Center of Excellence with you for a while. Some interesting things in COVID is we've seen a lot of, I was seeing this pre-COVID, but I think COVID has probably furthered it, which is a gravitation toward the primary care space. As you know, Center of Excellence contracting really started with surgeries, but the truth is in COVID, nobody really wants to travel or is traveling. So there's been a lull in this space, but what we've seen keep moving is primary care centers of excellence. I talked to you about these guys last year. This is 32BJ. It's a labor union in New York. They got in the press because they took out ads blasting a local academic medical center as being too expensive and drove them back to the bargaining table. They also noticed partner with Mount Sinai to create a very successful center of excellence program for joint replacement and bariatric surgery. I read, I think that they went from 20 to 60% market share with those union members for those surgeries. Well, now they've, like many, they've started applying the center of excellence concept to primary care. They created clear financial incentives for the union members to choose, notice, non-hospital affiliated primary care physicians. Interesting, no? Why? Because their assumption, and I hear this a lot from employers and unions, is that independent physicians are going to be the more effective patient advocates. They're going to make more cost-conscious referral decisions. I'm not telling you I agree. I'm just telling you what I hear from them. I've told variations of the story to you for a while now. So PepsiCo in Texas, setting up a center of excellence of sorts with primary care physicians and picking them from the remaining independent groups. We've seen a lot of these stories. We've seen enough of them now that it's clearly becoming a trend. The challenge, of course, remember, is this only works in markets, Dallas, New York, and so forth, where there are still significant numbers of primary care physicians who are independent. In many of the towns that I serve, that's long gone, right? They're all affiliated with some hospital or health system. All right, last but not least, let's talk about insurance companies. On the surface, man, it seems to be a really good place. I'm sure you've seen the headlines. The health plans have raised their earnings predictions. They've raised their revenue guidance, usually with at least a bit of a tone of embarrassment given the pandemic. Today, the basic math is this: the savings from all the deferred electives and avoided ED care have been much, much higher than any spending that they've had to do on COVID. As a result, they are simply flush with cash. Sounds, I know, like a wonderful problem to have. It's a strangely somber bunch, though, I will also tell you. I talked to a lot of them. The problem, I think, first of all, the Blues are not quite as happy. They would tell you they're overexposed on the commercial side. They're worried about people losing their jobs in COVID, so that could hurt, some of the smaller plans. But really, what's the real issue? What's keeping these executives up at night are not the 2020 financials. It's really the outlook for 2021, which is a giant gray area. Remember, the insurance industry does not cope particularly well with uncertainty. Predictability is the lifeblood of insurance, and all of the assumptions that they rely on to set premiums have basically gone out the window. In fact, some of the strategies they're using this year to increase utilization and to meet or get closer to their medical loss ratio targets are actually making it even more difficult for them, ironically, to anticipate the future. I think the best example of this is telehealth. In the short term, it seems like a no-brainer for an insurance company. It's a way to increase utilization. It gets them closer to their medical loss ratio targets. It hopefully preempts deferrals in care that could lead to much sicker people and big expensive spikes in utilization downstream. But also, I hear this all the time, real misgivings about the impact of telehealth on the total cost of care. That a lot of health plans feel, this is going to set off a sort of epidemic of unnecessary care. Physicians won't be able to see these patients, put eyes on them, which means they're going to start requesting more tests and diagnostics out of fear. I don't know that that's true, but I hear this all the time about telehealth. Nobody knows long term if it will prove to be a big cost savings device or in fact just the opposite. So again, in sum, if there's one thing I want you to take away from this part, it's that we're not seeing major purchasers pull back from affordability. Despite all the talk about resilience and the need for greater investment in healthcare that's happening on the campaign trails for both Biden and Trump, it's still all about spending control. We're not seeing those immediate price cuts in Medicare, but I would remind you they're definitely a medium, they're not a near-term prospect, but they're a medium-term prospect. It's a very real near-term possibility in Medicaid. Employers continue to push for steerage, in particular centers of excellence, and then the health plans are doing historically well in terms of their margins, but have a lot of misgivings about premiums and different clinical implications for next year. All right, let me turn now to the next section, which is partnership. You could be forgiven for if you read the press, judging by the headlines of the past few months, you could be forgiven for thinking that physician practices are on the brink of extinction. My personal favorite is the prediction of a, quote, mass exodus of doctors from the healthcare profession. This was an article in Biz Journal. I want to call them like, really? Where are they going to go? Are they going to go all work for SpaceX? Not so fast there, Biz Journal. Now, I don't mean to make light. Physicians are feeling very real pressures as a result of COVID. But I think the right question we need to answer is not whether are there going to be any doctors left in America. Of course there will be. But will this change their allegiances? Will physicians seek safety in numbers? And if they do, with whom? What's already clear, though, is that we are not, I want to be clear about this, we're not seeing a bunch of fire sales. When you talk to economists and strategists in March and April, a lot of them are anticipating this, right? That you're going to see just huge numbers of physicians go to private equity or to health plans or to hospitals and health systems. When you pull back the curtain, what you see on the right is that they've been propped up successfully by a number of structures, which means if they want to remain independent, they can. And if they sell, they've largely been able to get valuations at pre-COVID prices. Between CARES Act money, small business loans, advances from health systems and health plans, physicians have been able to attract enough funding to scrape by. Also, I should note the ability to use FaceTime and Skype to do telehealth in a HIPAA-free world has really been a huge help in terms of getting some revenue coming in with minimal investment. But again, my point is, if you look at the things on the right, the longer the pandemic goes on, the shakier some of these things become. Some of them are already pretty shaky. If you take even one of them away, I think we're in a different place. So who's at risk? I think you know this, small primary care practices, small single specialty groups. Least at risk are the huge multi-specialty groups, the big primary care practices that are still independent, particularly if they have capitated payment. That's been a godsend in this COVID pandemic because, of course, they get their money up front and they're not reliant on foot traffic to keep dollars coming in. The point is, there's no fire sale yet, but man, are there a lot of buyers out there. Physicians have more willing partners than they've ever had before. I put the list here. Which suitor rises to the top depends on the market and the specialty in question, but I think it's increasingly clear that they have a lot of suitors. Let's look at the two that are getting most of the press. On this slide, we seemed primed, if you go back to March and April, for a flurry of private equity deals. At the start of this year, the economy was very strong. This infused a huge amount of money into private equity. Even when the stock market crashed, it happened so quickly that most of these folks were still holding on to cash or dry powder, as it's called in the industry. Now, things have been on pause. Nobody's getting on airplanes. Nobody's going to make deals, but this could change fairly quickly. They have a lot of money, and they don't pay fair market value in the way that health systems have to. On the other hand, notice on the right-hand side, I think I've seen signs that we're definitely leaving the honeymoon period in terms of private equity and doctors. So there's been an increasing number of negative press articles about the role of private equity in healthcare. How much value do they actually create? I've noticed this. I have a Bloomberg article among the many I've seen there. We've also heard a growing number of dissatisfied physicians who have been very vocal, increasingly vocal about them feel that they're regretful that they took PE money. As you know, I don't need to tell you, doctors listen to other doctors. So if it becomes a big movement in the physician world to say private equity was a mistake, you would definitely see a cooling effect. I should also note, if there are any major bankruptcies, back in April, Envision, the PE-backed physician group, said that COVID had pushed them to the brink of bankruptcy. If you see somebody like this go under, I think you would also have a cooling effect in terms of deals. The other power players sitting on a mountain of cash are, of course, the health plans, as I noted. They're also motivated to keep physician groups independent when they can, keep them out of the arms of health systems. Humana and Optum have been the clear heavyweights in the space. We expect them, when they're doing this well, to double down on their efforts. We're even beginning to see the Blues dip their toes into the water. Again, most of the time they do looser partnerships with doctors, but we started to see some outright major acquisitions as well. I'm sure you heard in April, Blue Cross Blue Shield of California, Blue Shield subsidiary called Alteus, announced that it was going to acquire Brown and Tolan. That's a massive, nearly 3,000 physician group in Northern California. That's a night and day leap from a smaller practice that the Blues might have acquired in the past. So again, that really shook up the market. This trend of tighter alignment is not happening in a vacuum. Employers are also throwing their hat in the ring and saying that they would prefer that there not be a consolidation coming out of the troubled times of COVID. We've seen a bunch of examples of that. What about horizontal? You can see here in the first quarter of this year, before COVID really came down on us, 2020 was on pace to be one of the most active deal-making years, hospital to hospital, that we'd seen in a long time. You've seen these numbers before. You can see, again, it wasn't 2018, which was a record year, but it was second, really, to 2018. Most of this has been disrupted or put on hold because of COVID. Not all of it, but most of it. But I think these numbers are also a little bit misleading. In some ways, they exaggerate consolidation, and in many ways, they understate it. If you look at what goes into the transaction numbers on the last slide, there are 4 distinct types of deals that are represented in a transaction. So when I say that this sometimes understates the amount of consolidation, if a big system acquires a small community hospital, that is one transaction. If 2 giant systems come together, so for example, I'm sure you've heard that Beaumont and Advocate Aurora are talking about merging. If the 2 giant systems like that come together, that is still, by the way, one transaction. So in that sense, it underplays consolidation. But I would also notice toward the right, these numbers also, transactions, also include divestitures and breakups, both of which cause a market, of course, to become less consolidated, not more. I should also note that the trend toward disaggregation has been increasing for some time now. I started to see an increase in this a few years ago. Most of the stories were big chains selling off smaller hospitals, which is hardly a new concept. But I just would tell you that the volume of those stories I noticed started to increase. Even more interesting are breakups between some big systems. I listed some of them at the bottom, especially some that had merged only recently. And it's not just divorces that are on the rise. You probably noticed this, that more deals have been called off at the altar lately. It's tempting to read these as a mark of failure or merely as inevitable consequences of better due diligence. Maybe this was, they're just getting smarter about these things. But I actually think there's something more significant happening here. I think this reflects a growing recognition that the value from scale is difficult. It's not a given, and that the traditional benefits of pricing leverage are not always now justification enough to warrant the hard work of consolidation. What I think this is a very promising sign. All too often, the tendency in the industry has been to rush into some of these deals, assuming that the benefits of scale would just somehow magically and organically follow. As anybody in this call who's worked to create systemness can tell you, though, it's incredibly difficult to achieve. So I think what you're seeing here is a more healthy skepticism, and that's not a bad thing. It doesn't mean that all deals are off forever. I think it means that the deals we make will be better and more realistic. All right, let me move on to the next section, since we only have about 15 minutes left, and I want to talk about some changes to the care model. The big story, obviously, this year has been home-based care. COVID has raised questions about the appropriate setting for pretty much everything that we do as humans, right? So it's my anniversary, by the way, so I'm going to take my wife to a restaurant, I think. I think it's open. They don't take reservations anymore, and you're only allowed to eat outside, so hopefully it won't rain. But again, it's just a different experience, obviously, for all of us. Do I work from home and continue to hear dogs barking and blenders, you know, chewing up stuff in the background? Or do I go back to this office that's weirdly empty? Am I going to send my kids to school here in Ohio this fall? It's unclear if they're going to go hybrid or partial or virtual. And consumers have made a lot of these decisions about healthcare too, as they've gained more experience with virtual technology and become accustomed to care in the home. I could spend a lot of time talking about this. There's a long list of services that have the potential to shift or are shifting to the home. And as you can see on this slide, they span the entirety of the continuum of care. COVID is undeniably impacting all of these things and accelerating them. But I would just warn you that this period is not a great predictor, I think, of where we're going to end up. There are three of these we could talk through. I'll take you through actually the most important one. It's not the one I get the most questions about. The one I get the most questions about are virtual care, you know, sort of telehealth, and of course, senior care. Those are the big ones. But let's do the conversation around something that hasn't been in the headlines as much, because I think this is actually a big lessons to be learned about what's happening in the home infusion space that will inform our perspective on what could happen anywhere. And of all three of the shifts that I mentioned, or any of the ones on this slide, home infusion or ambulatory infusion represents, I think, outpatient, the most direct threat to the core hospital business. Purchaser demand for home infusion has been growing for some time, and COVID has been a massive accelerant. Employers have been searching for cost savings opportunity in the pharma space for a while now, and we did see even, you know, last few years, a growing consensus that infusion was one of the places to start. Some employers, as you know, even offer infusion services. You know, if they have big warehouses or big manufacturing facilities, they have their own clinics to do this. Patient preference, I grant you, has been a bit of a mixed bag. Some people love this, some people don't, but again, that's been washed in a tidal wave of COVID. It's been a huge accelerant. I've had infusion centers tell us they've shifted up to 3/4 of their business to the home in just the last few months. Medicare has historically not reimbursed for infusion in the home. They relaxed that like everything else during COVID. The House even drafted up a proposed bill to make some of these changes permanent. But I want you to know the real power player on the infusion front is the health plan. They've gotten deeper into the pharmacy space. They've gotten deeper into the care delivery business. And this has created clear alignment of financial incentives to accelerate these shifts. First, they're encouraging, or even some cases requiring, providers to source infusion drugs from their own payer-owned pharmacies. Plans pick up the revenue from the sale of the specialty drug, and as an added benefit, that gets some savings on the benefit side because they avoid the provider markup. The second opportunity on the right comes from payers actively steering infusion patients to their own ambulatory sites. This is a big deal. For all the talk about infusion shifting into the American home, we think the shift to ambulatory is the much more obvious trend because of the obvious revenue opportunity for plans that have an ever-growing ambulatory footprint. I need hardly remind you that the big losers in this scenario would be hospitals and health systems. In markets where this is already happening, in fact, I have seen three distinct responses. I put them at the bottom. On the first group on the left, it's a small group, but this is the group that's standing firm. Mayo Clinic is clearly in this group. This is a classic center of excellence argument. The quality of my care is so damn good that even if the unit prices are slightly higher, your total cost as a payer is going to be lower. We'll get the diagnosis right, we'll get the treatment right, we'll get the dosage right. That's a great strategy. Realistically, I don't know how many people could pull it off. In the middle, a bigger group of organizations I've looked at who are adapting and embracing the shift and trying to stay ahead of it to a point. Ohio Health in Columbus has built an algorithm to identify, okay, these people are appropriate for ambulatory, these people are appropriate for hospital-based infusion. Let's get ahead of it, go to payers, and make the case. And finally, there are some organizations, probably the biggest group, who are simply taking it on the chin, a good old-fashioned price cut. I've heard about payers willing to keep infusion in the hospital setting, in return for rates coming down sometimes around 20%. Realistically, unless you're willing to make the investment to stand up your own ambulatory or home infusion business, which is of course risky in its own right, this is probably where most people end up. A couple of lessons to take away from this. One, it takes a lot more than patient preference to shift care out of the hospital setting. So many of the predictions that I read out there today are based primarily, if not solely, on the assumption that more patients want to receive care in the home. That's nice. I'm sure it's true, but a whole host of other things have to be aligned for this to actually happen. It's not enough that it's something that patients want, unfortunately. Second, site of care shifting is not something that is done to anyone on this call. All too often, we tend to talk about it when I talk to health systems as, it's a force beyond my control. It's like a hurricane. Policymakers and payers are demanding it, and I have to react. But I think what the infusion example makes crystal clear is that the healthcare industry has a lot of agency in how this plays out. And actions that individual stakeholders take are just as important as anything that a purchaser is demanding. All right, we only have a few minutes left, so I want to talk about supply chain. So I'm going to skip forward to those final slides. And again, these will let me just engage you in that so we don't miss it. These are the three biggest areas of spending, as you know: supplies, infrastructure, and the workforce. But in closing, let's talk about what's happening specifically in the area of supply chain, since that's the business of the folks here. Supply chain has been a top cost savings priority, as you know, for years. The people on this call, right, the VPs of supply chain, I've met a lot of you, have been laser focused on negotiating lower prices, concentrating their spend. I remember going to a great conference run by a device company that's actually on the call today. They they invited the head of a big academic-based health system to talk, and I remember him saying that they had gotten down to 2 vendors in spine care, and I complimented him, and he said, that the Cleveland Clinic had 1. So we've been trying to negotiate lower prices by concentrating spend, trying to avoid excess inventory through just-in-time inventory management, like so much of the rest of corporate America. Now, a lot of those efforts have been attacked in the face of the pandemic because the argument has been made that there was not enough slack in the system when the pandemic hit, that we did not have the resilience we needed. The irony of that story is I don't know any VP of supply chain who would tell you that they were done, or maybe even half done. Again, don't get me wrong, I don't mean that as an indictment. They've successfully negotiated pricing down, they've limited excess inventory. The problem is, if you talk to them, severe lack of transparency has meant that we could not use the supplies that we have as efficiently and as effectively as we need to. I've had supply chain leaders tell me they spend half of their time, literally 50%, just trying to get an accurate read on their inventory. So my point is, we weren't done in terms of best practice. So many of the shortcomings that we've seen in the supply chain, ultimately we find come back to this chronic issue of visibility. I see it upstream. I know this has happened to a lot of the people on this call, manufacturers who did not realize how much they relied on shared sources for raw materials. So when countries closed down, they had massive disruptions in production. I see it downstream. Hospitals, again, as I said, generally don't have a good sense of their own inventory levels, despite a lot of work, making it almost impossible for them to shift things around and preempt shortages. So many of the challenges I think we've seen in COVID could have been mitigated, if not outright avoided, if we'd had more successful visibility. So I'm going to argue to you, and again, feel free to push back, but that a truly resilient supply chain is not one where we have to build a warehouse, to stockpile things behind every hospital. And it's not a world where we never buy anything from China again, but one that's transparent enough to enable the flexibility and agility that we need in the face of another crisis. we're never going to know exactly what we'll need for the next crisis in this country. The goal is not to stockpile everything under the sun, but to have the structures and processes in place that enable us to pivot far more successfully than we did in the height of COVID. Enhanced visibility also has the added benefit of unlocking between the people in this call, of course, many better opportunities for collaboration and additional cost savings opportunities as well. All right, I know we are largely out of time. I will just say in closing, supply chain has been a great area for investigation. Bed capacity, as you know, has been something of a bright spot. It's not saying that providers in hard-hit areas haven't had capacity constraints. Certainly, we got close in New York City at the height of the crisis. But the truth is, when it came to bed capacity, we had enough slack in the system. That might surprise you, since we've significantly decreased our inpatient bed count in the past few decades. But the truth is, largely thanks to all the reductions in length of stay, we still had beds. On an average day, the American system runs at about a 64% occupancy rate. Last year, when I talked to payers, this was a cause of consternation. They would rub their hands together and talk about how much waste and inefficiency was in the American system. I will tell you, COVID has meaningfully changed that conversation. Everybody seems happy with a little bit more cushion. So as we emerge from the crisis, I think our fixed restructuring efforts will, for a while at least, shift away from reduction in beds. Nobody wants to close a hospital right now, toward more flexibility, not dissimilar to the things I said in terms of the supply chain. All right, Nancy, I know I'm out of time. I know you wanted to say a few things in closing, so I will turn it back over to you, please.
Thank you so much, Ford. This has been a great program, and I know everyone who's with us has learned a tremendous amount today, and we really appreciate your spending time with us and taking the time to give us some insight as we build our way out of this crazy crisis that we've all been in for a while now. Just wanted to make sure our members and guests understand or know about our next program, which is going to be October 13th, the next program for our leadership community, talking about distribution. We have a panel of distribution leaders who are going to be giving us some insight there. And then you can see the additional upcoming programs for SMI members, and in some cases, they're invited guests that are coming up. We're going to be releasing our first podcast at the end of September. Donna Drummond interviewing Tom Poland, from the CEO of BD. So we're looking forward to having everyone have access to that on an on-demand basis, and continue to participate in the programs that are coming up for members and for our members and guests. And Ford, again, thank you so much for being with us today and for taking your time to share this great ideas, great insights with us. We all need to learn more and more these days as we try to figure out the best path to move forward from this crisis. So I want to thank you and thank all of our attendees for participating today. And please give us your feedback. There will be a feedback opportunity at the end of the session. So please share your feedback so we can continue to improve our programs in the future. Thanks, everyone. Have a wonderful afternoon.